Hello, good morning, and a very warm welcome to Thinking Out Loud at HOK. It's really good to see you here again. Lots of familiar faces. Thank you for coming along. My name is Farah, and I'm the marketing principal for HOK's London studio. And so to our speaker this morning. Andrew's parents were born in Egypt. His mother's family was from Cairo and spoke French at home. His mother trained in ballet as a child. His father came from southern Egypt and was amongst the few from his community that attended college. His parents went on to be world travelers, and each of Andrew's siblings was subsequently born on different continents, including Europe, Africa, Asia, and North America. Andrew was born in Michigan and raised in Ohio. His earliest memories from grade school was finishing his homework as fast as possible and then turning over his assignment to start sketching and drawing cities and buildings. He was genuinely torn between studying medicine or architecture. Andrew was also especially close to his older brother, who was a doctor. Undecided, he set out to pursue both professions, as you do. Andrew came to London in 2005, initially to study architecture at the Bartlett. He then subsequently returned to the US to attend medical school and to train in general surgery. Further along in his career, he was also keen to find mentors in both architecture and health. As Andrew became closer to the design element of how buildings are designed, he realized that having clinicians in architecture could make a significant difference. At the back of Andrew's mind was always the question of how we measure and improve the delivery of healthcare. Andrew went on to study a master's in health policy at the University of Michigan. He has since published over 70 papers that have been included in the Journal of American Medical Association and Health Affairs and New England Journal of Medicine Catalyst. His findings and research papers have also included the impact of Obamacare. Andrew was appointed to the American Institute of Architects, Design, and Health Leadership Group to explore ideas on how health can be incorporated into architecture. And we are also very lucky that Andrew decided to join HOK in 2018 as our first Chief Medical Officer. And so, without further ado, I am really very happy to introduce the incredibly talented and exuberant Dr. Andrew Ibrahim. Thank you, everyone.
Good morning. It is really great to be here in London. So many friends, old and new, and so much nostalgia just walking back through Bloomsbury again this morning. What I hope to do in the next 30 minutes is to inspire you that health in all design is not just an idea, it's not just a concept, it's actually a tradition that goes all the way back to the beginning of architecture, and that we're at a particular moment in our history where architects have the opportunity to be at the front line of health and healthcare if we realize the vision of health in all design. In our first earliest recordings of architecture, we find that Marcus Vitruvius wrote his 10 books of architecture and very explicitly early on made the connection of health and medicine. He said, "The architect should be equipped with knowledge of medicine, for without these considerations, the healthiness of design cannot be assured." In fact, he made many more connections to health and architecture. Many of you will recognize this drawing by Leonardo da Vinci of the Vitruvius Man, but it was really Marcus Vitruvius's idea that our best and most effective design ought to mimic the proportions of the human body. Again, very clear in our history and earliest foundations that health was actually at the core of architecture. Centuries later, Avicenna, the 9th century polymath, a physician who was well-traveled, made many central contributions to our understanding of medicine and healthcare, including recognizing that disease didn't happen arbitrarily and that it was actually located in specific places, and that the places where you live and work and interact actually has an impact on your health. Of course, this would be the same pattern that John Snow here in London in the 19th century would also recognize when trying to understand the outbreak of cholera. Health has always been a central thread woven deep in the history of design and architecture has always stepped up to the plate to recognize and take on our most pressing challenges in healthcare. But is that still true? If I asked you today to think about the most challenging problems in healthcare, the things that keep you up at night, the things that bother your family, the things that you worry about in your own health, who would you turn to solve those problems? Doctors would certainly be on your list, I hope. Surgeons, perhaps, scientists, policymakers. But do you think of architects? Do you think of architects and designers as central to improving your health and well-being every day? I would challenge you further. I know many of you in this room have been involved in large-scale infrastructure projects, long-term planning, spaces that we use every day, and ask in that design, who was sitting at that table? Was there someone at the table who could ask a very fundamental question? Is health a priority in our design? Was there somebody there to explicitly say, are we making our decisions so that the people who occupy this space are encouraged and enabled to live a healthier life? It's clear to me that from the history of architecture, architects have always been central in improving our health, and that we have a real opportunity to reclaim our role of being on the frontline providers of improving health. If we step back and think about where we are in healthcare today, it's the most expensive, complex, and uncoordinated that it's ever been. In fact, when you look at life expectancy trends in the UK, and it's the same in the United States, for the last 3 years in a row, it's been on a decline. In fact, we are the first generation whose life expectancy is actually lower than the generation before us. How's that possible? How is it possible that with all the modern advances that we've made in society, all the technology we have, that somehow healthcare, of all things that is so important to us, has fallen behind? It may lead you to ask the question, has healthcare actually gotten worse? Is it plausible that the way we deliver healthcare is worse? I certainly don't think so. I've dedicated a good part of my life to becoming a clinician and have been privileged to be part of some really unique moments. One of the most transformative moments I've ever been a part of in my clinical care was the first time I got to participate in a kidney transplant. We had flown out in the middle of the night because we learned that a kidney was available for a young child who had been born with a genetic disease, and had they not gotten this kidney transplant, they'd be on dialysis their whole life. So we flew to a neighboring state in the middle of the night. We were able to bring back a kidney to this young child, and for the next few hours, we started sewing these small blood vessels, half the width of a pencil, under magnifying glasses to really make sure these were the perfect stitches. And as the blood supply started to go to this new kidney, you literally saw urine coming out of it, and we'd sew that into the bladder. And I remember myself just sitting there in recovery, watching a catheter fill full of urine, and just being so amazed that this is where we've come in modern medicine, that we could literally transplant entire organ. When I later sat with the family at bedside, outside of a wedding, I think, I've never seen so many people crying and smiling, and literally just staring at a catheter filling full of urine. Even more remarkable, when I talked to the transplant coordinators afterwards, they told me that in just this 48 hours of care, more than 70 people were involved in coordinating care just to make this possible. We're truly in such a remarkable era of healthcare. It's hard to think that we've gotten worse somehow. In the BBC News recently was a story about a group of doctors who had actually performed surgery before the child was even born, and able to correct a spine defect well before it would have been recognized otherwise. But for all these modern advances, for all these services that we have available, it's worth asking, are these specialized services available to most people? And if we dig even deeper, is this actually what most people need most of the time? There's been a good body of research that's tried to understand what are the determinants of health? What are the things that change our day-to-day well-being and health? And when you look at healthcare, where I've spent so much of my time, the doctors, the clinic, the nurses, the hospitals, the trauma bays, turns out that only accounts for about 10%. So even with the best hospital in place, the best doctors in place, that can only account for about 10% of your health. In contrast, when you look at our day-to-day behaviors and the environments where we live, work, and play every day, that accounts for more than half of our overall health. In other words, if we want to improve our overall health, it's not enough to just have great health care, although we will and will always need that. We also have to think about how do we make health a priority in everything we design. So what might that look like? How could we imagine health as a priority in everything we design? How could we take our roles as architects who want to reclaim a central role in improving health and actually realize an improvement in our overall communities? When we think about the problems that are most pressing in our societies, it's hard to ignore these three: depression, obesity, diabetes. Certainly in the United States, as well as here in the UK, these are chronic problems that affect so many of us. And fortunately, more recent evidence has come out that the way we change our built environment can have an enormous impact. Let me tell you about a few. The Journal of the American Medical Association is often the journal that we go to as clinicians for the frontline medications, the newest surgical procedure, the largest randomized trials. So it was quite a surprise last year to find this study published about vacant city lots. It was from the city of Philadelphia in the United States, where they had 541 vacant city lots throughout the city. And they randomly assigned each of these lots. Some of them were kept vacant, others were simply just cleaned up, and the others were cleaned up and landscaped. What was the overall result? They found that they tracked the health of the people living in all these communities, and those that lived in the communities where the vacant lots had been landscaped reported 42% lower rates of depression. Quite remarkable of a finding, but also quite remarkable that this is the type of research that's being published in our top clinical journals. Another study, also from the Journal of the American Medical Association, looked at the built environment in Ontario and started to assess what is the walkability of these different neighborhoods. Are there places where there's a certain density of people where you can interact with your community, where there are destinations that you can go to, where you can have access to the things that you need for day-to-day opportunities to be physically and healthy? What did they find? They found that the people who lived in the most walkable neighborhoods over time, that neighborhood actually had an effect on them, and that over time, those people reported lower rates of obesity and diabetes. Again, a remarkable finding of the impact of our day-to-day environment, but even more remarkable that this is the type of research that is coming into our top clinical journals. It's hard to think about the built environment without thinking of the buildings that we spend most of our time in. Most of us will spend 80% of our life inside a building, and it's worth thinking, what does that building do to your well-being, to your day-to-day health? And it was a surprise to me to learn that this was an undertaking recently of the Centers for Disease Control. The CDC in the United States has a long history of infectious disease outbreak. They're well known for understanding the HIV epidemic. They became popularized in culture for the Ebola outbreak. And what did they focus on in the last 3 years? Healthy buildings. Dramatic shift from where they had been. They developed the Fitwell Standard. The Fitwell Standard was based on 3,000 research publications that tried to bring together what's the best evidence that we currently have to take a space that we spend so much time in that might influence our health in a positive ways. They identified a number of design elements that we could focus on and change explicitly to make these buildings healthier. Amongst them were stairwell design to encourage active behavior, access to healthy food, access to public transit, indoor air quality, and others. In just a couple years, nearly 800 buildings have been registered with the Fitwel standard, and it is not a coincidence that the CDC has done this. There's actually been a significant large demand from clients. Recently, the AIA surveyed clients in the United States who are planning large-scale infrastructure projects in the next 3 years and said, what are your priorities in the next build that you have? 84% said they aspire to have health explicitly addressed in their buildings. These weren't necessarily healthcare clients. These weren't people who came from a health background. These were the everyday cross-section of clients across all building types. And in fact, when you look at what made the top of the list, you realize that nearly all of these things could be influenced by our built environment, and nearly all of these things have such enormous implications for our health. How we deliver sustainability of our energy systems, the healthy buildings with the elements I just described to you, or spaces for social interaction and collaboration. We now have so much research understanding that loneliness actually is becoming one of the largest risk factors for being unhealthy. And now employers and people building our built spaces have recognized that design has the opportunity to change that. One of my favorite parts about being an HOK is that no matter which office I go to, healthcare is only a small part of the practice. And I couldn't resist being in one of our offices, overhearing a group of our architects talking about stadium design. And they went on about how beautiful the stadium was and what the entertainment value would be and what the sport there would be like. And I couldn't resist asking. I'd been preparing this talk for months, and I said, what could you do to this stadium to redesign it with health as a priority? Could you imagine this space in a different way, that instead of just being an entertainment venue a dozen days a year, it could actually be available to the public every day? And that it was a space that you could go to for physical activity, place for social gathering, place to access healthy food, to learn new behaviors and habits. And sure enough, they agreed, and we spent most of that day, and in fact, we booked time the next day to start planning what would the world's healthiest stadium look like. And there were several design modifications that we came up with that you could certainly implement all of these concepts and ideas, that we could really leverage the design of one of our largest public infrastructure investments to actually impact the health of the community every single day. If nothing else, it showed me that if you made health a priority at the beginning of your design, you can actually fit it into any design phenotype. Now, so far, I've talked to you about health in the built environment and healthcare. I haven't said anything about hospitals. I didn't say anything about clinics. And I haven't told you much about physicians either. The truth is, a lot of the impact that we're going to have in the next decade may have very little to do with these, but in fact, the buildings that we design every day. So think for yourself about all the spaces that we have the privilege to design, develop, and plan, and what a privilege that really is. And then think further, how could those be imagined with health as a priority? Now, this is a talk about healthcare. After all, I am a surgeon who's here talking to you. And the subtitle of this talk was Healthcare Beyond 2030. So why have I spent so much time talking about the built environment and buildings and social determinants of health? Well, it turns out the landscape has changed a fair bit. OBAMACARE, as many of you know, the Affordable Care Act, was legislation passed in 2010 that fundamentally changed the way we think about health and health outcomes. There were many expected changes that came after the bill. More people got health insurance. There were a lot of deliberate incentives to improve the quality of health care. But there were some unexpected changes as well. Because so many hospitals were small and independent and could not handle all these changes at the same time, they began to consolidate into networks. So no longer was there a single hospital working on their own, but a group of 10 and 12 hospitals with accumulated resources now responsible for entire districts or regions, much like we have in the NHS Trust here, who now had a very different view on how they might impact the health of the people they care for. And this has really come to light in our insurance industry. Blue Cross and Blue Shield is one of the largest private insurers in the United States, and they have been very public about the change in their model. They took a lot of interest in identifying who are the most vulnerable people in their communities, in their society, that they're responsible for insuring, and what could they do to invest in the health of those people. I think if you asked any of us a decade ago, the answers would involve hospitals, clinics, and physicians. But what are health insurers investing in now? Healthy food and housing. Nearly every insurer in the United States has a large and growing housing portfolio, and all of them are trying to understand what are the ways they can make the communities where their people live healthier. Part of that has been identifying neighborhoods without healthy food and making sure they have access to it. It's also meant enabling safe, stable, and healthy housing. And in doing so, they noticed enormous changes in not only the health of the people in those communities, but it's actually saved them money. It's not only been the right thing to do for people's health, there's actually been a real business case that it's the right thing to do to save money. Across all insurers, the model has really changed that we now value the health of the people who live there rather than just delivering as much care as possible. And our focus, rather than just being what happens to you when you're sick, is what can we do to impact your life and improve your well-being in the places where you live, work, and play. Imagine for a moment that we could pull this off. Imagine that for the last 15 minutes, I've been so compelling and so inspiring that all of you agreed health is going to be a priority in everything we build and design, and that everybody goes back to their clients, goes back to their offices and says, hey, we just have to do this. It's the right thing to do. More concerning to me is that if we looked back a decade from now, how would we know this design philosophy worked? How would we know that this was the right idea, or that we just wasted a lot of time and energy and public money for the wrong reasons? How would we know not only that it was the right idea, but that we were on the right trajectory to improve the work we're doing? Thankfully, there is a roadmap for how we might do that, and it comes from one of my surgical heroes, Ernest Codman. Ernest Codman was a surgeon in the 19th century who was operating at a time of endless possibilities. Ether had just been discovered, so you could actually put a patient asleep to do surgery. X-rays had just come over from Europe, so you had advanced imaging and diagnostics available. And what resulted was not only could you identify the problems of everyday people, you had unlimited license to try to intervene as a surgeon. So you could imagine surgeons operated all the time. And Codman became very concerned, not that the ideas didn't sound good, not that they didn't seem to be the right thing to do, but that nobody knew if they worked. He saw many of his colleagues performing operations and noticed patients didn't do well. So he proposed what he called the end results idea. And it's the common sense notion that every doctor should follow every patient treated long enough to determine whether or not the treatment has been successful, and then to inquire, if not, why not, with a view of presenting similar failures in the future. I think most of us would agree that if you came to me as a consultant and wanted me to perform your operation, that I embodied these same ideas, that I cared about how you did after the operation, and that I wanted to know if it was an operation I was performing all the time, that it was actually helpful to people down the road. Well, Ernest Codman was quite unpopular at the time. Surgery was a private industry. You made most of your business based on reputation, and nobody wanted to air their dirty laundry. In fact, nobody wanted to know if their operations worked or didn't work. Famously, on his tombstone, he said on his deathbed, "It may take 100 years for my ideas to be accepted." And in fact, he could not even afford his own burial. And only in the last 30 years did the American College of Surgeons go back, find where he was buried, give him a proper burial and tombstone, and on it has this same exact quote to remind our profession that it is such a privilege to be able to intervene in people's lives in such meaningful ways, but we also have a responsibility to know if what we're doing actually helps them. His legacy went on to establish many clinical registries. We now have more than 5 million patients who are enrolled in registries where we track what operation they have. We know about their health disease profile, and we know how well they've done after surgery. In the last 4 years alone, we've written 10,000 research papers that help us better understand what are the best treatments that we should be providing, and what are the ones that we thought were great ideas. When we studied them rigorously, realized it wasn't a good idea after all. Obviously, I think that idea goes well beyond surgery, and I think it has a lot to do with our topic today of health in all design. What would Ernest Codman say if he was sitting here with us? He'd probably say we had a beautiful building and that he appreciated the breakfast, I hope. But I think he would channel his end results idea and ask the common sense notion that every architect should follow what they build long enough to determine whether or not it has been successful and improved health, and then to inquire, if not, why not, with the view of preventing similar failures in the future. Imagine a world where architecture reclaimed its position as a frontline provider of health. Imagine a world where we not only had these great ideas to make health in all design a reality, and that we could make meaningful changes in people's lives every day, but that we could also find a way to make it measurable. You may be wondering why a surgeon trained in policy is spending their time in an architecture firm. And the truth is, as I spend time in both worlds, the lines have become more blurred. Now more than ever, that connectedness is needed. And if taking the best lessons of academic medicine and what we learn from policy to change the day-to-day design of our lived life with the way we build and design everything, I can't think of a better mission. I want to ask you one more favor. Many of you have been so gracious with your time. You've come in to work today. You've come in, you've spent your time here, been very diligent. But in a few minutes, after you catch up with some old friends, you'll be right out the door. You're going to get back on the tube and go to the West End. You're going to go back to your workplace. Perhaps later today, you'll be back at home with your family. And I want you to think of all the places that you're spending your time, all the spaces that you're around every single day. Think, is health a priority in those spaces? In the place that influences you so much, where the things that were designed that make your health and well-being better every single day. And even more, what could you do to make that space even healthier? So with that, I will say thank you, and thank you again for your time this morning. I think we have a few minutes for some questions if anyone is interested. And I'll just ask you to say your name and the question, and then I will try to repeat it.
Thank you very much indeed. I'm Angela Harvey. I'm a non-exec director in the NHS for a Mental Health Foundation Trust, not very far from here. And I'm also a local councillor in Westminster and have been on planning for quite some time. And reading that across to my professional life as well, what you're saying about how the place must support our health, I'd like you to focus just for a moment on mental health most particularly, because It's something that, thankfully, is much further up the agenda today than it was a few years ago. But in the UK, we have places called Maggies for people with cancer. I'd like to understand where you have seen the best mental health provision, where it's been provided by either the NHS or more widely around the world. Thank you.
Thank you so much for your question. And just to briefly rephrase or to repeat the question, essentially, what is it about health in the built environment that we could change related specifically to mental health? I think one of the points you made initially is enormously important, that mental health has become no longer taboo and that we can actually talk about it openly and recognize that it's a problem that affects all of us and doesn't discriminate based on your education level or your gender or your background. It affects it affects without discrimination, and all of us are susceptible to it. I think two areas that stand out to me from health and the built environment that are quite important. One is this idea of social connectedness, the idea that just because you have a mental illness, it doesn't make you isolated from the rest of society. So the things that we can do in our built environment to create spaces where it's easier to collaborate socially, easier to be connected in our societies, I think that is important. And I also think the walkability or density of areas that make it such that it's easier for you to get to the places you need to go. So that if you need to go to an appointment, you need to go to the clinic, you need to go to grocery, all of that is accessible, ideally within walking distance. One other initiative specifically related to mental health that's become a big part of our health practice has been taking away the stigma of mental health by locating those clinics in the same places as our wellness and fitness facilities. So that when you go to the gym or to a mental health appointment, you are literally walking in the same door, and that nobody knows why you went in. And in fact, for the patient themselves, we shouldn't actually be distinguishing the energy that you put into your wellness and the energy that you put into your mental health, because they're both equally important. Thank you.
I have a question. Since you came to London, you'll have noticed how many homeless people we have on our streets here. It's a big problem, you can see. And I'm wondering what your approach is to the solution that they have found in Finland, which is to give homeless people a home.
Certainly. So I'll speak from the United States perspective too, in that from a health perspective, there's no question that being homeless has a detrimental impact on your health, and that providing stable housing significantly improves your health. Who or what is the shared collective responsibility of how we should deal with that? In the United States, much of that falls on health insurers, so there's actually a real business case to be made that providing safe and stable housing is actually cost saving. I also just think that's the right thing to do, that no one should be left out on the street. There, I think, could be a lot of innovative work that's been done in efficiently providing safe housing. And I think we have an opportunity to innovate in that space and how we could do that in a way that has a lower cost overhead, that we could provide housing. But there's no question that that should be part of our collective responsibility, and that health, I think, should be one of the primary arguments or principles for why we should provide that service.
Hi, Ed Fitzgerald, also surgeon, now Global Healthcare Executive at KPMG. Andrew, thanks for a really interesting and inspiring talk. I'm going to ask you the difficult medical question.
Please.
You finished with a really good call for action for architects. But I think if you look back on healthcare professionals, in my experience, it's pretty rare for us to think about design in healthcare. So what do you think needs to change in terms of health professional education training? If you could say something to medics to help them really focus and think about this more greatly, what would you say?
Brilliant. Thank you so much, Ed. And the question was essentially, what could you do for the health professional body to start to recognize or improve our understanding of the importance of design and architecture? So part of our work at the AIA for the last 5 years has been actually building curricula One, for architects to understand some core principles of public health, but in fact the opposite as well, to introduce some basic ideas of design to healthcare professionals. So there are a handful of pioneering programs that have launched, one by Bon Ku in Philadelphia, who has an entire design track in the medical school, and every year enrolls 20 students in design teaching, where they get mentored by designers and architects, and they intern in architecture practices as part of their medical education. So I think the more we can collaborate and start to blur the lines much more explicitly, I would love to see many more clinicians working in architecture firms, and I'd love to see many more designers being part of our healthcare research groups. I think the more we can blur those boundaries and break down those silos, we'll start to realize that a lot of the benefits could go a long way to realize this vision. And Ed is being modest. He's a good example of somebody who's trained in the traditional clinical sense, but has gone much beyond that to embrace much broader ideas outside of the hospital, including design and architecture. So you're a good pioneer as well, Ed.
Morning. It's Anthony Comidis. I've got a question with regards to the Fitwell standard you mentioned. There is also the wellness standard. Out of the two, which one would you think is more relevant for what we do these days?
Sure, I think both have emerged. Well standard came out first. They both essentially raise the same issues of what are the elements of the built environment. I think they each have some trade-offs. Some have more measurement requirements, but are a little more detailed and granular. I think for every project, it'll be a little bit different. There may be some where the well standard really is more appropriate and fits that client. So probably not a blanket statement of which fits better. But if you're in that scenario and trying to decide, I think you'd have to evaluate both and see how it fits into your project. But there's some scenarios where I think the Fitwell does just fine, and there's some where well may be more appropriate. So.
Just one maybe provocative question. Maybe it will sound.
That's the kind we're looking for.
Yeah. So, you know, for example, you came here and you just advocate that we should take like health serious as one of the factors that affect architecture and our design. Although today you are wearing a tie, don't you? Could you just tell us how the tie affects your health? And if you can just measure and you just quantify if this tie with a different color, let's say red, blue, or white, it's gonna have an effect. And you see, my point is that, as you know, architecture, it has this kind of spectrum that we are working, and it has to do with aesthetics. And therefore, of course, if we design a space, it's better than have like an undesigned space. But this it doesn't answer if a good design is going to be better than a bad design. It's very difficult to quantify. That's also the question. And the second question is that, you know, that the buildings used to live for thousands of years, or used to. So it's also difficult in terms of logistics to try to quantify if, for example, like the National Gallery was a successful building in the 7th, 18th, 19th century, and if it is right now, and how competes with a modern building that was built south of Thames, like in the Tate Modern, for example. Thank you.
Good questions. I think at the core of your question is health in all design is not always going to be a slam dunk. There are going to be competing interests. Designing for health may at times be more expensive, may at times may not be the right aesthetic that you want, and it'll be just like all the other priorities that we have to balance as stakeholders and take into account. And I think one of the beauties of training in design and architecture is that that's the privilege you have. You get to take in all the stakeholders and try to say, here are 10 competing interests that you have. What are the ones that are most valuable to you? My only message today was include health as one of those 10. Put it on the table as a possible discussion point. I'm not saying that it's going to win every time, but I at least want it to be on the table. I think we're out of time. That's the last question, but I will stick around and chat some more afterwards.
It's interesting because this week is World Wellbeing Week. As an organisation, we embrace that. We have a lot of initiatives within our organisation. So to see this in a different light, especially with healthcare, healthcare is quite negative within the UK at the moment. So seeing another perspective of healthcare and looking at wellness, Fitwell standards are a new one to me, so it's really good to see. It's really good that we're embracing this more. So it's a very fresh perspective from my perspective. And it's glad that the journey continues wherever you go now. We're talking about wellbeing more. So it's good to see that we can change healthcare, hopefully. We've started a journey with HOK on a new project in London, on a new hospital, and hopefully we can embrace the kind of these standards within the hospital itself. But I think the journey is going to be about stakeholders and taking the stakeholders on the journey as well. I think if we can change the mindsets, we can change people's perceptions, we can deliver this through our buildings, that would be amazing.
I thought it was great. I think it's always possible to incorporate healthcare in design. I liked the kind of indices they said people were looking at in terms of the diabetes, looking at depression, as well as that loneliness factor as well. I think that's something that people don't really realise that you should be incorporating into the design of buildings. I think also as engineers, architects, project management, we need to be taking responsibility definitely for the incorporation of healthcare into design.